sure Mandana's part is
Hello.
okay. She closed the door. Yeah, okay.
I asked for permission to record Leona just so we have a recording of it. I don't know who is the meeting owner, but can they allow me to do that? The host? It apparently needs the host permission.
Okay.
Recording in progress.
Oh, perfect.
Thank you. Yeah. It's okay. Okay, good afternoon, everyone. Good afternoon, everyone. I hope you can hear me. Give me a second. Hello, hello. Okay, everyone can hear me? Thank you for joining our session today. I'd like to start off by giving you a brief overview of who we are, who Nutrition International is. So for over 30 years, we have been working in nutrition, and we have been focusing on delivering high-impact nutrition interventions to those in need. We serve as an expert ally to governments who need technical expertise, but also program implementation on the ground. And our expertise is having a flexible, cost-effective approach. We provide technical assistance, evidence generation, capacity building, advocacy, and outreach. And we partner with various actors at the global, regional, and local levels to improve global health guidance and break down silos between different ministries and across sectors to better prioritize and also mainstream nutrition. And we are headquartered in Ottawa, Canada. So in terms of our global reach, we operate in more than 60 countries. Here in Asia, we have physical offices in India, Pakistan, Indonesia, and Bangladesh. And we have our regional office out of Delhi, so South Asia is a huge priority for us. So who do we serve? We serve everyone. However, we do focus on 4 target groups. These include pregnant women and newborns, children under 5, adolescents, and women of reproductive age. The reason that we focus specifically on these groups is because, unfortunately, these are the most vulnerable. More than 1 billion adolescent girls and women in the world suffer from malnutrition. Malnutrition widens gender inequalities in terms of future earnings and lifetime potentials, increases the risk of health complications during pregnancy and postpartum, and endangers the future development of children. Worse, malnutrition is passed down from mother to child, perpetuating the cycle of intergenerational poverty that we seek to break. Given this background, it is logical that we focus on anemia reduction and prevention in our region and globally. South Asia has the highest rate of anemia. It disproportionately affects the 4 target groups I had mentioned, and low mid to lower middle income countries also suffer the highest rate of anemia, particularly those rural populations that we cannot reach. The World Health Organization has set a global target to reduce anemia in women by 50% by 2025. However, we are off that target. That's why we're here today to lead this session. Today's session has 3 learning objectives. It is an interactive session. We want to show you what the consequences of anemia are and why addressing it is so critical for our region. Recognize the multifaceted etiology of anemia, so what causes it, and why context-specific interventions are needed. Lastly, we want to teach you how to learn the existing tools, information, and country-specific data that's out there to design actions to effectively address anemia. Unless you have the proper causes, and anemia is a complex one, then the rates will not change. Our aim today is to identify and treat the multiple complex causes of anemia, which run across the gamut and have ties to not only nutrition, but also diseases, such as malaria. So you'll be hearing today from 3 of my colleagues at Nutrition International. We have Dr. Mandana Arabi, who's our Vice President of Research and Development and the Chief Technical Advisor for Nutrition International. We have Minnie Verghese, who is our Country Director in India, and Saika Siraj, who you heard at the opening plenary, who is our Country Director in Bangladesh. Following their presentations, I will lead you through a group exercise where you will have the opportunity to put into practice the theory that you hear using the WHO's 5-step roadmap to design an anemia action plan. So without further ado, I'd like to hand it over to Dr. Mandana Arabi. She sends her regards and regrets that she was not able to join you in person, but we have her dialing in from New York. Over to you, Mandana.
Thank you very much. Just a quick sound check. Can you hear me?
Yes.
Perfect. Thank you. Hi, everyone. Thanks for joining the learning session of Nutrition International today. It's an honor and pleasure to be joining you today, albeit from far away. And I hope that you are all having a great experience at the conference. Next slide, please. So I'm not seeing my slides. Okay, perfect. You go to the previous one. And the previous one. Okay, I'm missing my title slide, but that's okay. Let's start from here. This is good. So I will be talking about how we will be able to address anemia and plan a multi-sectoral action plan based on understanding the causes. And we will be walking through a process, a methodology for you to be able to do this. And also you will have a practice session to exercise and work on the data that will be country specific. And hopefully by the end of the session, be able to have these tools ready for your application when you go back to your positions in your countries. So just speaking a little bit about anemia. Anemia is a public health condition. It could be due to reduced number of red blood cells or low hemoglobin concentration because of blood loss or ineffective production of red blood cells or destruction of red blood cells. And all of these can lead to consequences that could range from mild to severe depending on the stage of anemia and the level of anemia. It could be causing fatigue and decreased productivity. It could cause poor cognitive and motor development in children, poor birth outcomes, both for moms and the babies, and increased morbidity and mortality in adolescent girls, women, and children, especially the ones who have severe anemia. This all goes so far that it causes, at the global level, more than 50 million total years lived with disability. And we also know that if we invest in preventing and controlling anemia, for every dollar invested, we could yield more than $12. So it's a very cost-effective approach also to try to solve this problem. And when we look at the numbers for cost of not acting to address anemia in South Asia alone, our data has shown that 21 billion US dollars would be the cost of not acting to address anemia in children, and 11 billion US dollars would be the cost of not addressing anemia in women of reproductive age. So as you see, it's costing all of us and all of our communities a lot because this is a serious public health problem. Next, please. I wanted to show you a map just to give you a sense of the current status And where we see countries having mild, which is the pink color, moderate, medium red, and then severe, the dark red. And when we say severe, it's a high percentage in the population. It's more than 40% of population in these countries, unfortunately, are dealing with anemia. So in women of reproductive age, as you see here, almost all countries in Asia are suffering from this, and several have severe levels of anemia. Next, please. Similarly, this is the map that shows the situation in young children. And again, you see that we have, unfortunately, countries, almost all countries in the Asia region have anemia in children, and then moderate and severe in several of them. It's quite widespread. Next, please. So we have initiated working together at the global level to address anemia in an effective way. One of the challenges with anemia is that it has different causes, or what we call etiologies. So this framework that has been developed through the Anemia Action and is published by the WHO is showing that there are 4 key categories of causes. One is micronutrient deficiencies. Many of us working in the field of nutrition are familiar with it. Iron deficiency anemia could be contributing up to 50% of anemia, but it's quite a range, and it really depends on the specific population, health conditions, and diet risk factors. There could also be infection, inflammation, and chronic diseases, and they all cause potentially anemia. And there could be obstetric and gynecological conditions, such as heavy menstruation in women, or hemorrhage and bleeding during childbirth, for example, and these could also cause anemia that stays and doesn't get solved on its own if we don't actually address them and provide the fixed treatment to women. There are also inherited red blood cell conditions or disorders, such as thalassemia, sickle cell, which are again specific to the genetic makeup of the individuals and the population. But we need to have an understanding of the situation before we are able to address the anemia. Next, please. So as I mentioned, WHO brought together a group of key actors as a way to renew our collective actions to address anemia. A comprehensive framework for action has been developed. I showed that to you briefly, but this document is also available. It focuses on actions to prevent, diagnose, and manage anemia. We want to tackle direct causes of anemia in a comprehensive way. It proposes 5 key action areas, and I'm going to walk you through all of them. And it also talks about how you go about addressing interventions and how you go about integrating sectors. And finally, currently, Nutrition International and WHO are working together to develop an operational guide that will allow very practical, hands-on, programmatic focus that would allow you to use this global framework, but make it implementable at the country and subnational. Next, please. So the first action area is analyzing data on causes and risk factors for anemia. As we talked about the fact that there are these 4 key categories of direct causes that you see on the left, we cannot have a comprehensive plan without looking at the data across all of these causes and having a good understanding of what's going on in all of these categories. There are several sources of data that we are proposing here that could be used for having a better picture. We can use national surveys, the Global Health Data Observatory. There could be vitamin and mineral national surveys or nutrition information systems. Again, the Global Health Observatory includes data on infectious diseases such as malaria, HIV, helminths. You also need to look at the situation in your country in terms of postpartum care and whether you have possibly data on what is the situation or the suffer from this, and just have a better understanding of whether this category of causes needs to be seriously addressed. And then finally, again, on specific inherited blood cell diseases, these are related to the genetic makeup of populations, and it's important to look at the publications and understand whether these are also part of the risk factors in your country or in the community you're looking at. Next, please. So while the action area 1 was about understanding the causes, action area 2 is then about prioritizing the preventive and therapeutic interventions that are evidence-based and will have a way to address the causes that we already identified. So priority interventions include screening for anemia. It could include looking at micronutrient deficiencies and addressing them correctly through supplementation, to, for example, folate supplementation or weekly iron folate for adolescents. It would be about preventing and treating infectious diseases. It could be about managing and strengthening the health system, skill-based delivery for reducing gynecological obstetric conditions, and other more comprehensive ways, such as family planning, again, screening and management of disorders, and bringing all of these interventions together. For understanding the interventions, again, the outcome, the information resources that we have listed here will also have them as your learning packet today. Next, please. Third action area is about optimizing service delivery across platforms and sectors. So we looked at causes, we matched them with the right interventions, and now we have to think about how do we get to those interventions to the populations that need them. And in order to do that, we need to use different delivery platforms. Of course, health system has been a platform that has been used and will be used. But here you also need to look at other sectors that have the possibility of taking some of these interventions to your populations. It could be the education sector, delivering supplements to young people, or it could be agriculture sector, making certain types of highly nutritious food available. So you need to have a comprehensive integrated approach. And again, for this, there are some resources that we have here available, and you can look at them. These are resources that as part of the Anemia Action Alliance we have consolidated, and helps you understand which sectors at what levels need to come together. And this hopefully makes your multi-sectoral work a lot more targeted and focused for action. Next, please. Area 4 is about strengthening leadership, coordination, and governance. So as many of you who work in systems know, you would need to have support from the leadership. You need to advocate for programs. You need to get the messaging right. You need to really influence the decision. And in order to do this, you need to show data, you need to package it in a way that's impactful, you need to communicate well. And there are, again, tools for doing this. One of the tools I wanted to introduce to you today, which Nutrition International has developed and is open access, is called Cost of Inaction. And this is a tool that allows you to look at the indicators of the children or anemia in adolescent girls and women, choose your country or region, or even go for global data. And it shows you then what is the cost of not acting in that region. And this is a very powerful tool because it shows the decision makers the big loss that this important public health problem is doing. And hopefully it could be one of the key information that you share as you're communicating about the importance of anemia. Next, please. For example, here, we chose the data for India, and you will also be able to use this as you're doing your exercise today, where you can actually have your country-specific data and the country. So, again, for example, here we see for children in India not addressing anemia will cost up to $17 billion in annual economic. Next, please. And finally, action area 5 is about expanding research, learning, and innovation. As we talked about the complexity of anemia as an issue, as a public health problem, the multitude of factors, risk factors, causing, and then the interventions, the sectors that need to come into play, we also need to have an understanding of what has been tried, what the evidence is showing us, what are key success factors, and really build on whatever has been done, body of evidence that already exists, and then take that forward. Again, another tool that actually we will be launching next week together with the 3IE, Nutrition International, has developed a tool called an evidence gap map for nutrition and anemia for anemia. So the evidence gap map for anemia allows you to choose the country, to choose the specific risk factors or specific causes, and then the evidence gap map actually shows you what is the consolidation of evidence that exists. So those are the dots that you. And you can already tell there are some areas where there is a higher concentration of dots, means many more papers, publications were possible to find there. But then there are some places where, as you see in this map, there we could not find any evidence. So that tells you that there needs to be more research potentially, especially if those are key factors that are in the population you're working. The tool is interactive. It's going to be available online, and then you can actually go click on each of these boxes, and you will actually see the list of publications. And this is something that is a resource, instead of you having to go basically search for articles one by one, everything is consolidated and categorized here and can be accessed, as you see in the top bars, by country, by age group, by a specific disease area or a complication or intervention. It's all about an evidence map to address anemia in a comprehensive. Next, please. Again, I just wanted to highlight one of the uses of this. As you see here, we chose Bangladesh for looking at whether there is anything in the literature, looking at the linkage between gynecological and obstetric conditions and anemia. And you see actually here, we did not find a lot of publications. So this seems to be potentially a gap area for them to do more research to understand whether these conditions are contributing significantly to the anemia, especially in women. And we know that in many contexts, they actually do. So right there, by using the gap map, we have identified a gap area. Similarly, if we had chosen other topics where there were more dots there, we would have been able to see the multitude of resources that are available and then use them for our programming and plan. Next, please. And then finally, just wanted to close by showing you an overview of what our organization has been doing in the anemia space. Just also celebrating and acknowledging, again, many actors have been, governments, nonprofits, the UN system have been addressing anemia, have been implementing interventions. And, these interventions include larger scale fortification, universal salt iodization. For NI, we actually have a salt that has iron in it, so that could address anemia. Weekly iron folate supplements, and then maternal and newborn health and nutrition, which would include infant iron folate supplements or multinutrient supplements. That's something that we are exploring, whether the switch would be beneficial to the country. So just to show you that, again, there are already programs that are in place. We do acknowledge that they need to be a lot more integrated, as we spoke about them today, and not all causes are nutritional. So the challenge next for all of us would be to come together and see how we can integrate across the different causes, across the different interventions, and hopefully bring all of our resources together and work in a much more concerted effort and in a much more collaborative. So thank you so much for being here today, and looking forward to the learning session and also to learning from you and to staying together as a community to work on anemia together. Thank you.
Thank you so much, Mandana. So Dr. Mandana Arabi joining us there from New York. So I wanted, before I hand it over to our next speaker, I just wanted to speak to some of Nutrition International's work in anemia. So we are a founding member of the Anemia Action Alliance. Our CEO, Joel Spicer, is a member of the steering committee, and we have led the development of background papers for the WHO Comprehensive Framework for Anemia Reduction, Dr. Mandana Arabi being one of these key contributors to these papers. What is really interesting as well is that we developed a landscape analysis on the prevalence of anemia for African Union member states. We were requested, and we have had a long-standing partnership with them. Here in the Asia region, we tend to work on a country-by-country basis. So we have been a key technical partner to the government of India's flagship program, Anemia Free India, which we'll hear about in a minute. And we have also been asked recently by the government of Bangladesh to serve as a technical partner to support the development of a comprehensive anemia action plan. And I think, as you heard from Dr. Mandana, it is so important to have the right causes, but it is complex, the etiology. It's not one single cause. So really getting anemia embedded in a multisectoral, multifaceted approach will be key to driving action moving forward. And the other bit is the importance of financing these costed anemia action plans. So the cost of inaction tool that Mandana spoke to will be a great advocacy resource. We won't have time to go through that fully today, but we are on hand if you have any questions. I didn't have a chance to introduce myself in the beginning. Apologies for that. My name is Leona Liu. I'm the External Relations Director here in Asia for Nutrition International. So I'd be very happy to guide you through that cost of inaction tool with our Health and Economics Department. I head all the advocacy partnership efforts, and as Mandana said, it is a free public good. It is not just for NI. We want you to use it widely in your efforts for pushing policy legislation in your respective countries on anemia. So next, I'd like to introduce Minnie to the stand to give us a country-specific overview of anemia in India. Over to you.
So thank you, team, and thank you for the audience. So India, the issue of anemia is one of the, it is categorized as the severe category of public health. The reason is that it is cutting across all the age group, cutting across all the genders, and socio-economic standard, anemia is widely prevalent. So that makes us to work very concentrated when it comes to anemia. So India is also historically, if you look at it, is one of the first few countries in the world to have a population-based anemia program. So the population-based anemia program for pregnant women was started way back in 1970. So we have a 5-decade-old anemia control program for one specific age group, which has started in 1970. And it has went several revisions over a period of time. And in 2018, this has been revised to make it more comprehensive, because anemia actions are not limited to one sector, one alone. Therefore, looking at cross-sectionally to see that what it takes, the multi-sectoral action for anemia being there. So the program in India is called Anemia Mukt Bharat, which is translated to Anemia Free India. In 2018 it started. With an ambitious target that every year we reduce the anemia rate by 3%. It's globally, it is one of the very challenging target being there. So what is the set target? So it's also important to see that the action on anemia cannot be done by one partner or one government or one ministry. So this is also an effort of multiple partners, UN agencies coming together, deliberating and coming out with a framework to address anemia in India through this approach. So this approach is called 6x6x6, which is required 6 beneficiary group, has 6 different identified proven intervention, and 6 institutional mechanisms to be looking at it. This is also identifying vulnerabilities of the specific age group where anemia actions are required. So you know that children 6 months to 59, children between 5 to 9 years, adolescent girls and boys between 10 to 19, women of reproductive age group, pregnant women and lactating women, and children of 0 to 6 months in case of preterm or low birth weight being the case. The intervention which has been identified include prophylactics, IFA supplementation, deworming, behavioral change communication, which including delayed cord clamping. The evidences are very strong for that, and digital hemoglobinometer to test, and which will encourage people to undertake treatment, use of fortified food in public distribution system, combating non-nutrition causes of anemia, because it's expected that though in India it says that between 30 to 50% iron deficiency, the remaining 50% is, or even more than that, is non-nutritional and hemoglobinopathies in nature. And the institutional mechanisms, which includes the Anemia Mukt Bharat unit within the ministry, the coordination that required between the ministries, a robust supply chain mechanism which is required, because which is consistently been seen a challenge within Indian setting, convergence with different ministries like rural development, water supply, women and child, so there is convergence between different ministries, and a focus institutions to look at anemia, that is the National Center of Excellence in Advanced Research that has been housed within All India Institute of Medical Sciences, and Anemia Mukt Bharat dashboard, so that the data which will drive us to take decisions rather than in the absence of a lot of data which we do it. So this data portal gives monthly performance of states and district to see that where are we, and also there is a ranking of states being done to closely monitor this program. In Nutrition International, we have been working across the all the three of these approaches in 6 of the verticals being there, with varying degree of depth as well as scope that we've been working on it. We probably do not work in the space of deworming because there is an exclusive partner who works on the deworming space with the Government of India. Therefore, we are. But otherwise, we work across all of these areas, specifically more closely with the state government to operationalizing this plan, as well as at the national level for greater coordination and focus. So I would just take all of you to a little history about Nutrition International Anemia programming. It's close to 15 years since the time that we have been working on this anemia, starting in way back in 2010, where there was, we do not have a policies around anemia, addressing anemia in adolescents. So we have worked to establish evidences in back in 2010. Several, because being India being very wide in nature, varying in nature, so one study do not support it. Similarly, the other partners also contributed in different parts of the country, which led into adolescent anemia, addressing adolescent anemia as a policy had come up in India. So we have been very focused manner, we have been working from 2016. So our adolescent program reached about 135 districts across 5 states of India. And the maternal IFA program, which has reached about 68 districts. And however, after 5 years of work, we realized that there is more things need to be understood when it comes to the maternal IFA and calcium, the maternal nutrition component of it. So currently we are doing an implementation research to understand what it takes to deliver IFA and calcium to pregnant and lactating women, and especially their compliance. No? So with a focus on compliance, because that has been a key challenge within India, when if 50% of the women receive, only 25% they consume, what the desired number of the tablets which is being provided to it. So on the adolescent program, currently we are working in 96 districts across 5 states. Our support, which includes state level as well as at the district level, to making sure that actions are happen at the field, which include capacity building, behavioral change communication, a range of support services being provided. In addition to this approach, we are also currently supporting Government of India in implementing the fortification program through public distribution, which include the rice and the double fortified salt, use of double fortified salt, which is fortified with iodine and iron being the thing, which is currently being done it across 4 states of India, and rice fortification around 5 states of India. And one of the critical component of services is also on delayed cord clamping. So in 2 states, around 28 districts, we are also focusing to see that how, because our institutional deliveries are really gone up in India, like close to 90+% of institutional deliveries happening. So we are using that as an opportunity to say how do we implement delayed cord clamping, which also saves and protect the child for first 6 months of their life. So these are some of the programmatic support and policy and programmatic support that we have been providing to the program. So I will stop here and I'll invite Saika to talk about the Bangladesh. Yeah.
Thank you so much, Minnie. And I think I got introduced in the first session, so let me move forward quickly because we want to spend more time in the group, activity. So let me quickly go through. So, like Minnie has said, like in India, Bangladesh is also anemia has been a major public health problem for many years. In 1970s, at the very beginning of Bangladesh, from that time, an anemia prevention program has been launched. In 2007, then later on, a comprehensive strategy was developed to combat anemia in the country. We do work with 5 groups, target groups, starting from the children under 5, adolescent girls, women of reproductive age, pregnant women, and lactating mothers. So these are the target groups that, through the government program and other initiatives, we are trying to kind of, implement the anemia prevention program. For children, the intervention is more vitamin A, deworming. For adolescent girls, initially we started with weekly 2 IFPRI tablets, and then 3 months of administration, 3 months of gap, which was very difficult to administrate. So we went for a weekly IFPRI tablet all day around for women of reproductive age, especially for adolescents. So right now, what is ongoing is a school-based adolescent program. Then there is a behavior change communication, of course, attached to it, which is needed. Otherwise, as Minnie also said, the uptake is not as high, although there are available a supply of iron folic acid tablets for pregnant women in the system. Also, fortification was, through social security programs, were another approach that we had taken. For nationally, as I said, there is a national anemia prevention strategy, which covers pregnant lactating women, adolescents, and it's a community and facility-based approach that we try to achieve. In our National Nutrition Plan of Action, anemia is one of the indicators. In all the global targets, anemia is one of the indicators that we are trying to achieve and bring down. Of course, there are intra-ministerial coordination within the family planning and the health systems part, but also inter-ministerial coordination, like through school-based programs. Iron folic acid tablet has been distributed to adolescent girls all over the country. Through the community-based approach, the frontline workers, through outreach approach and facility-based approach, all pregnant and lactating mother, starting from the 2nd trimester of pregnancy until 6 months of after childbirth, they are supposed to take 1 iron folic acid tablet through this program. One of the challenges is always strengthening the supply chain, maintaining the logistics and the supply, which I think over the years has improved, and now there is barely a time where there is a supply chain gap. And we are also working on a costed, Nutrition International is working on a costed anemia prevention action plan, which will help us, have better understanding of not only doing iron prevention anemia control, which is now basically the program, iron and folic acid, which might not be the only reason why anemia is so prevalent in Bangladesh. So how Nutrition International supported and be part of this initiative of government so far? In 2000, this is the maternal and child nutrition part. So we started in 2011 to 2013 to do a pilot of how to really maintain supply chain, orient all the health workers, and have proper system in place through the health system. We started in 2 districts. We scaled it up. One of the major support and one of the major I would say initiatives that helped a lot is to do a formative research to understand why women are not coming to ANC, why women are not taking iron folic acid tablets. And due to that research, and from that, we actually were able to develop gender response sensitive information on iron folic acid supplementation, on ANC uptake, and that has helped increase the uptake of and consumption of iron folic acid tablet in Bangladesh a lot. So we scaled it up. We worked for a while. We are still working, scaling it up. And during COVID, there was really in some areas where ANC service as a whole were not happening. So we did put some outreach services and programs at that point additionally to support the program. For the adolescent one, we started in 2018 with government supporting them with a formative research to understand the adolescent nutrition scenario overall, and also with a focus to anemia. And then we did an implementation research in 2 districts, one school-based program and one for the working women in RMG, the ready-made garment sector. Both of them actually helped us to better understand what could be the modalities, how to really support government in progressing with the anemia prevention programs. From 2021, a school-based adolescent nutrition operational guideline was published by government with multiple stakeholders, including Nutrition International, supporting it. From 2023, there is an ongoing program where it is a nationwide program, but intensively nutrition education and IFS supplementation we are supporting in 11 districts in all the divisions, across all the divisions in Bangladesh. And because only 1/3 girls kind of go to school at the higher secondary level, and there's a lot of women young women who are going to, formal, informal sectors and getting married. So community-based approach is needed, which is missing now for the adolescent girls. So we are working with government to develop a community-based adolescent nutrition operational guideline, which will be published this year, or maybe early next year, because it's December. And then I'm missing the word action. There is a anemia costed action plan that we will be doing for, doing the research for next 2 years, which will then fit into the National Plan of Action 3 and the National Nutrition Policy, which will be updated soon in the coming years. So I will stop there and go into, the group exercise. To Leona, thank you.
Thank you. Thank you, Saika. So now for the group activity, just to let you know what we will be doing. You are already sitting in tables now. So stay in your tables, but we're going to split up into tables of 4. So for those of you maybe in that table where there's a lot of you, maybe spread out. So we want to have 4 groups total. You're going to get a case study packet that my colleague Trajita will hand out to each of you, so you can share that with the person next to you. There will be 3 steps to this exercise. Dr. Mandana had walked through that 5-step roadmap that the WHO has listed. In the interest of time, we won't be doing the last 2 steps, but we'll be doing steps 1, 2, and 3. So step 1, you're going to be reviewing the data to select the causes, right? And then on these flip charts, for each group, you'll be putting them on the flip chart using one colored post-it. In step 2, you'll be looking at the non-comprehensive list of interventions, and then on a different post-it colored note, after a group discussion, you'll put it on your flip chart. And then the third is to look at the opportunities to program and put those actions on the post-it. So you will end up having a flip chart of 3 different color post-it rows, okay, that you'll be doing in consultation with your group. And these case studies are specific today to India and Bangladesh. So depending on which table you're at, it will be done by random. You'll either be doing a case study on an anemia action plan for India or Bangladesh. And Minnie and Saika will be moving between the tables to support. Okay, and you have 20 minutes for this activity. And just as you start, let's just have a member at your table be designated rapporteur at the end to present the key actions on the post-its. Okay, so this larger table, could some of you maybe join this table here? Or, sorry, maybe do you want to join one of the tables there? Just to kind of get an even sense of numbers. Okay, so yeah, maybe we'll end up having 3 groups instead of 4. Yeah? Okay. Yeah? Okay. Okay. Great. Okay, and just in the interest of time, I will be giving you a signal. So you should spend about 5 to 7 minutes on each step. Yeah?
Also, Leona, can you hear me? Hello?
So I think each group has a set of post-its. So it'll be great for the purpose of categorization if you use different colored post-its for each of the steps. So please feel free to share your post-its with the other group. I can help facilitate that.
And just, Srijita, I think just give them a number, right? 1, 2, 3, yeah? And then you should put down the flip chart. Okay, and just for our final share at the end, just for clarity, where Minnie is standing, you are group number 1, okay? Group number 1 is India, case study. The table at the back, you're group number 2, and you'll be doing Bangladesh. And then the table up here at the front, group number 3, also Bangladesh. And we'll put the group numbers on the flip chart. So when you're finished with each step, you can put the post-its on your respective group number.
Hello, can you hear me?
Okay. Step 2, yeah? Yeah. Okay. So I hope everyone has been able to move on to step 2 by now. Okay. Yeah, if not, just spend another minute or 2 on step 1. But, you know, this is just 3 to 4 causes. Okay. So for the step 1, the causes, just want to clarify that you are just choosing 3 as a group to work with. There is no right or wrong answer, so don't spend too much time. You need to choose it so you can move on to step 2 and 3. Have they finished? Okay, so just please do move on to step 2. Okay, so move on to step 2. Now that you have the causes, you can select the interventions that will have the highest impact on the causes that you selected.
checking if you hear me.
Okay, um, so now that you have done, you're probably all on step 2. I'd like to recommend that every group, so I think there's a lot of dynamic discussion. I would recommend every group look quickly at step 3. Okay, so just to give everyone a heads up, I know that this activity could take far longer than the time we allotted, but just in the interest of time, you have about 5 more minutes. Yeah, 5 more minutes to complete step 3 before we close. Okay, everyone. So, just one more minute. We're going to wrap up. And for our wrap up, for your wrap up, we're going to have Mandana, who's been waiting online, to join us again to hear what you uncovered during this exercise and also to provide you a chance to ask any clarification questions to her.
Hi, can you hear me? Hello?
So we are actually out of time now. I would request one person from each group to go beside their boards who will quickly just read out. We don't have enough time to listen to all the explanations, so it will be good if you just read out what are the causes you have identified, platforms, and what are the interventions. So I would request one person from each group to be beside the tables. If few things are in your head, it's fine. You can just speak to it. Yes.
So we also have Dr. Mandana join us. Mandana, can you confirm if you can hear us?
Hi, can you hear me?
Yes, we can hear you loud and clear.
Great.
So we are beginning with the presentations. So, yeah.
Thank you. And before we jump in, just wanted to say that I'm here also with our extended team at the headquarters. We have Ana Maria Santos-Rosa and Dr. Daniel Lopez de Romania that have been part of the planning team for this session. So if you have any questions, also you can either ask if there are a few minutes at the end or reach out to us directly. My colleagues will be able to share.
Yes. So we are starting off with group 1.
So group 1.
Okay, group 2, please go ahead. That's fine.
Okay. So group 2 took the case study of Bangladesh. Please go ahead.
Yeah. Thank you, group 2, all the members. Under step 1, we have selected 4 major causes. Like first one is micronutrient deficiencies. Among micronutrient deficiencies, we have focused on zinc, especially zinc deficiency and vitamin A deficiency. The second one is infections, and especially under infections, we have selected like helminthiasis and tuberculosis. So the third one is postpartum hemorrhage, and the fourth one is thalassemia. So under step 2, what we have done, like we have selected interventions for all 4 causes. So for micronutrient deficiency, we have selected IFA supplementation and micronutrient powder supplementation. So for infection, to prevent infection, we have selected deworming and chemotherapy for like helminthiasis. So these 2 comes under infections. The third one is like to prevent postpartum hemorrhage. We have selected prevent and treat postpartum hemorrhage and optimal timing of delayed cord clamping. So these 2 interventions can prevent postpartum hemorrhage leading to anemia. And the fourth one is to manage thalassemia. We have selected 2 major interventions. The first one is like genetic testing and counseling, so that we can screen and identify on early stage, and then we have to manage the thalassemia. So under step 3, we have selected, we have selected interventions. So the first one is integration of delivery platform. So in most of the South Asian country, we have different service delivery platforms at the community level. Like I am representing Nepal, and I have also worked with the micronutrient initiative for 4 years. So I know, like at community level, there are so many like EPI clinics, health mother groups meeting, like and outreach clinics. So we have to integrate and we have to deliver all the health and nutrition services in integrated way. So that will work for us. And another one is NNC platform. So the counseling is very, very poor during the ANC visit. So if we can focus on ANC counseling, that can work for us. And then vitamin A supplementation with deworming, because in most of the country we have vitamin A supplementation program biannually. So during that time we can just focus on that. And the last one is school meal programs, where we can provide like fortified foods during the midday program, and so a lot of activities we can conduct under the school health program. Thank you.
Thank you. Yeah, a round of applause. Group 1.
From group 1 on behalf of group 1, I'm going to present in their picture. So we have reviewed the data that actually provided, and based on this, we prioritize actually ranking 1 under 5. I think they need actually need comprehensive program to prevent and manage the anemia. So for that group, we think like as a priority areas, supplementation, iron supplementation for children, we need to focus on this. Also connecting with the deworming. Since we are thinking this as a bundle activities actually are required, so connecting with deworming, and also umbilical cord cutting timing. That actually, and also I'd like to highlight here, we need to connect with the infant or breastfeeding promotion activities, because their newborn activities also promoted this message, clot cutting thing. Since there is a connection, we can add on this. We need to update this. And so this is for, and also that screening with, I think, the management of sickle cell disease, we show some high data, so we can focus on this. So this is first priority, and second priority is for women reproductive age group. But still this group has some data gap, but still something is there. So based on that, we are thinking of the ANC, ANC and PNC program, also prevalence for postpartum, reduction of postpartum hemorrhage, and also like other community-based nutrition counseling. So these bundle activities, I think, will address.
Thank you.
Thank you so much. Thank you.
Okay, last group.
Last group who is presenting
Group
for
three.
group 3.
Thank you for the opportunity, and we have identified several sections to mitigate. So what are the sections that we need to address to reduce the anemia? So we have identified the micronutrient deficiencies, and mainly the zinc, vitamin A and folate. And the second one, the inflammation and the chronic disease, include that the worming, that means the worm-based diseases and tuberculosis under 5-year-old children. And also the postpartum hemorrhage is one of the main reasons for the anemia. And we have identified inherited red blood cell disorders such as the thalassemia as the main causes. And for our second step, we have identified the potential intervention that can implement to eradicate this anemia. The first thing is the supplementation, that we all know about the supplementation, and in the South Asian region it's very common. So supplementation with iron and the folic acid and the multiple micronutrient in order to address the zinc and vitamin A deficiencies. And for the second thing, we identified the early pregnancy to mitigate or to prevent the poor outcomes of the early pregnancies and reproductive related problems, and also to prevent and treat the menstruation related problems, and also to treat, to increase the strengthening and the capacity building of the gynecological and medical conditions regarding the menstruation, pregnancy, and other during the delivery and other causes. And also we have identified the WASH, that means the water and the sanitation facilities, and it's very important to increase the delivery of the good water and sanitation. And also we have identified the deworming intervention as the one of the main interventions that we need to implement to eradicate the anemia. And also we identified the different platforms how we are going to going to give different interventions, as we mentioned. That first one is the antenatal clinics. So from that clinics, we can aware them about the childbirth spacing, the deworming, and the good practices. And we can also give them the behavioral change communication factors. And also we can give the awareness about the anemia. And for the second thing, community-based platforms, we can use the schools and mainly the preschools to give them the nutrition-related advices and nutrition-related advices to the parents, mainly the mothers, regarding the anemia conditions. And for the workplaces also, we can arrange the deworming sessions and other medical-related things, and also we can also implement the supplementation in the schools, mainly in the primary schools. We can easily do the supplementations. So these are some of the things, and also we can do the psychological-related counselings for the people who are already affected by this anemia and other conditions also. Thank you.
Thank you so much.
Thank you so much.
So I just wanted to thank you guys. That was such a short time. That was just 15 minutes. So you guys did amazing, and I hope you know this was just a taster. So now you have this roadmap. You can go back, do this with your colleagues, partners, and just to let you know, you have the emails here. And you can come see any of us. And these 2 QR codes for you is to join the Anemia Action Alliance. And the one here to the left is the evidence gap map that Dr. Mandana spoke to. So this is very important. I don't know if you caught it through when she was saying that they've actually mapped where's the research and the publications in each of these causes and what's actually missing. So from there, looking at the gaps, you can see what needs to be advocated within your country or region to really dig further into these causes. I think what we've seen and what we hope you'll take away from today's session is that effective anemia prevention and control requires the development and implementation of a contextualized multi-sectoral approach. So reaching across the aisle, different aspects of health, education, agriculture, WASH, to really have multi-sectoral nutrition plans. One last thing before I end is, as we announced, Dr. Mandana and her team, Daniel and Ana Maria, are online with us. So if there's any burning question, please raise your hand. I know our session's ending, but we can take a few questions for the team there. Otherwise, we look forward to staying in touch. Yes, we have one question here. Anyone else? We'll take all the questions together. You can pass the mic. Okay, and these will be, directed, Mandana's there.
Thank you.
Yes.
This is Sohana Shafiq from ICTDAB, Dhaka, Bangladesh. Great presentations and very interactive sessions. My question would be, Mandana, to you about this 3IE program on evidence gap map. So in the evidences, what was the selection criteria for the publication? Was it only the publications in the peer review journals, or the reports and other program-related data also was actually incorporated? Thanks.
Thank you very much. Thanks for the question. I would actually want to ask my colleague, Dr. Daniel, to come in because he's been leading that work and the methodology there. Daniel, are you able to speak?
Sure. Can everyone hear me? Okay, great. Yeah, thanks for the question. So the methodology is a very standardized methodology that 3IE developed. Our partner in developing this anemia evidence gap map. And it includes publications that are looking at systematic reviews, one, but more important, impact evaluations. Most of them, if not all, I would say, were peer reviewed.
Okay. Yeah, so I don't know if you could hear very well. I think we had an echo, but yes, it's mostly focused on peer-reviewed publications. We did try to search, if there are very well-recognized institutional publications like the World Health Organization and others, we did include those as well. But we also welcome you after we launched it next week. It's available, all the detailed methodologies, the papers, abstracts, and we're looking forward to getting feedback from the community to keep improving it in the future as well. So do write to us if you find things that are missing.
Yeah. Thank you so much. And as I said, there is that QR code. Please come see one of the members of the team. We can sign you up for that launch. It is free. It's online, and you'll be able to get all the data, the research. We also have these folders for whoever wants to grab with a list of references to what we discussed today, as well as that cost of inaction tool, which we plugged the numbers just very recently. So they are up to date for India and Bangladesh. So we're happy to share that with you. I know there was one last question here from Mandana. Was that? Yes. Srijita, could you share? So this will be the last question, just in the interest of time.
Okay. Thank you for sharing your knowledge. We got to know a lot about anemia management. So my question is, implementing anti-warming tablets, I think, to get the full benefit, the entire family to take it and the proper way we want to use it. So this project, are you providing it for the beneficiary or the entire family, or how to tackle that thing, like how to cover the entire family's requirement?
Thanks. So I think you're asking specifically about deworming and how it's being done. Of course, as we were walking you through, it's only relevant in context where the worms are an issue, it's identified, and the intervention is called for. The other thing for me to emphasize here, and we're trying to advocate for it more, is let's not just do that one thing, right? Let's actually understand if we are seeing, for example, helminths, worms, anemia as well. Let's also try to get data on other causes, because you could integrate the interventions. For example, doing deworming and testing and screening for, let's say, malaria and other relevant infections, and for iron deficiency anemia could be really impactful. So that you probably could provide deworming together with iron supplementation if the iron deficiency exists. So think about that integration aspect. And then whether to do for the individual, for the family, I think it really depends on the context. You're right, in some protocols, you can actually do preventive deworming for the whole household. So again, it really depends on what is the public recommendation, public health recommendation in that context. Our initiative is about, most of these interventions in a vertical way already have really established protocols, treatments. You see the very well-written WHO document. The challenge is that they're all vertical. So you see a document on managing, helminth infections. You see a document on iron deficiency anemia. What we are trying to do here is you cannot just have it vertically, because anemia in these populations usually is due to multiple causes. So what we are inviting you to do, and this initiative is trying to do, is to become much more holistic thinkers, to really look at all these different causes that are relevant in where you're working, and then see if there are other elements of other interventions to be.
All right.
And again, Nutrition International, for example, we provide technical assistance to help you do this thinking through. Just wanted to mention that as well, that they can also reach out to us and our technical colleagues to help them. This is something that they want to advance in their countries. They've already started working that in Bangladesh, as I mentioned.
Thank you so much. Again, Dr. Mandana, Rabi, to our other colleagues here joining us remotely, Daniel, Anna Maria, who helped put together this amazing learning lab. Thank you for your participation. And again, please do stay in touch. And thanks for joining today.
Thanks, everybody. It was great to be part of this so far.
We are moving directly into plenary, just across the corridor.
I hope you've all taken the folders. If you haven't, grab one now.